Hello, everyone. Welcome back to the GDR webinar series. We're very excited to be back. I'm particularly excited for this topic because I think it's an area where I think there's not necessarily a lot of information out there unless you're kind of going down certain particular routes. So I think it's really interesting to get different perspectives. Dr. Andrea Shepperson joins us from across the pond a little bit, and we're very lucky, especially with the time differences, for her to be here with us tonight. Suited to us Australians, so thank you so much for that. She comes with a wealth of experience as a dentist who's been experienced as a clinician for over 40 years now. She has a beautiful facility in Waiheke Island in Auckland where she runs a toothware and managing comprehensive program. She's incredibly experienced and is involved with the King's College in the UK, multiple other international institutions through research and so much more. So we're very, very fortunate to have her and her experience, where, especially when it comes to this topic, the smile design is really the start of, and a motivational mock-up is really the start of any comprehensive dentistry. It brings together diagnosis, it lends itself to treatment planning, and provides the vision for, really quite changing dentistry and transformative. So we're very lucky to have her. And today we'll be having a presentation. We'll have questions. Questions can, as always, can be asked throughout the presentation. If there's a moment there, I will intervene and make those questions available. Otherwise, we'll make sure every question is answered at the end of the presentation. So without further ado, welcome, Andrea.
Thank you, Alex, and welcome everybody from around Australia. It's a real pleasure to be part of the GDR program. Some of you, I'm sure, that I've met at different times when I've been speaking in Australia at different events. And so I'm going to start the presentation. Very interesting topic, and I think really pertinent topic, because I know that there's so much aesthetic dentistry being done, and particularly by younger dentists or perhaps less experienced clinicians. And this is really a safe way to evaluate a case before you pick up that handpiece and do something irreversible. So let me share my screen, Alex, and hopefully we'll all be good to go on that, and I'll go into full screen mode. Perfect. You're looking good here, Alex?
That's looking great. Thank you.
Wonderful. So I'm a digital smile design master and run a DSD clinic in New Zealand. So I've been involved with the DSD world for a long time, since about 2009, when I first heard Christian speak, and started doing DSD shortly after that. And so he talks about the wow moment in dentistry, and you're going to see why that's significant and how things have changed in the last 20 years in the way that I used to do my motivational mock-ups and the way I do them now. So just a little bit more about me. I live in Auckland. I've got a practice limited to toothware with a restorative focus predominantly. I live on an island, and this is the view. This is a photo I took last week, actually, because I take a ferry back and forth 3 days a week to the practice. And the rest of the time I'm on the island where I live, where I have my teaching centre. I'm married to Sean for 32 years, who's a chemist and materials scientist. And I've got 2 children, Oscar and Caitlin. Caitlin is studying, doing her PhD at Sydney University, and Oscar has just finished his PhD, and he's actually off at the end of a family trip that we leave on Saturday to live in Glasgow. For however long. He may be one of those Kiwis and Aussies that goes overseas and never comes back. Hopefully not. So when I'm not at the practice, which is about 115 days of the year, I'm teaching and traveling, and I get around the world to different events. I'm very much a digital practitioner. I like gathering with global leaders in the field, and here's a little collection of friends from the UK, Europe, and one Kiwi, and several people from the USA, and some you may recognize, some you may not know at all. And I did a presentation last year for the first time at the COIS Symposium on toothware and GERD. Just a very short presentation, but it was a real honour to be invited to speak at the annual COIS Centre Symposium, where I'm a mentor, and I'll be up there in June if any of you are going to the Koi Centre for the first time, staying around for a week to mentor the new dentists who are coming in. This is where I live. This is Waiheke Island. Beautiful spot. You can see my teaching centre. This is it here. Designed for small group teaching of up to 30 people at a time, and really beautiful place to teach. So there we are. That's my teaching centre in Waiheke Island. Short ferry ride to get there, and it's literally in my backyard, which sounds kind of weird, but it's also kind of cool. So let's talk about and this is just one of the things that I'm really passionate about, which is toothware. This is my publication, which came out about just a year ago, March of 2023. This was published worldwide for those of you who are interested in toothware. And I run hands-on programs, including a 6-month mentoring program, which involves webinars, a couple of weekends at the centre doing intensive hands-on, and then we do one-on-one mentoring in between times. So I know Alex sort of sent you a few links and some of the material that he has sent out to the group. So why do a mock-up? And the other terminology that we use often is the test drive or the trial smile. Well, number one, it provides an enormous amount of validation that your facially driven design and what the lab has sent back to you is actually going to be harmonious with the face, is going to work phonetically, and will also work functionally. It allows you to engage with the patient and get feedback from the patient before you've done anything irreversible. And I think that's absolutely critical. There's nothing worse than starting treatment, delivering it, the enamel's been cut, the veneers are on, and the patient's unhappy. So this is the part where we mitigate red flags, I guess, at this point. And I'm going to share some examples with you where we've had to do multiple mock-ups to satisfy the patient with high expectations. And communication. So it's a lovely feedback tool. It's where I get to see the patient talking, laughing, speaking with a mock-up in situ in the mouth, and really is very different from just doing a 2D design that you might do, in, say, the old DSD app or Smilefy or, whatever presentation software you use for that. So you'll see before and after 2D simulations, smile simulations, but that is nothing like the 3D mock-up that we can do. So for me, it's these key things. Very much an intraoral 3D, very close approximation of the final aesthetic goal for the patient. I can create predictable and reproducible outcomes by doing a mock-up and knowing that I can then deliver dentistry that looks virtually the same. So what we call in the DSD world, the copy-paste technique. I mentioned that I can do phonetic, aesthetic, and functional assessments. It's not fixed in place, typically, the mock-up. So it's difficult sometimes to do all the functional assessments that you want to do, because when you ask the patient to chew and grind, you're probably just going to pop the overlay or the mock-up off the teeth. And that's the final aesthetic and or phonetic and functional assessments can be done at the time that you make the provisionals, but you want to be reasonably close at this point. And then all of those lovely feel-good emotional things, patient excitement and engagement, getting diagnostic confirmation for me that I'm on the right track, and then also that I'm going to be able to deliver biologically what my mock-up is suggesting. Feedback from the mock-up enhances lab communication. Just the critical thing, it is absolutely reversible. You do it, you take it off at the end of the appointment, and it gives the patient who's a little bit anxious reassurance and approval before you've started treatment. It's interesting that some dental associations around the world are now starting to write codes of practice that say that actually for any extensive treatment, you really should be visualizing the result for the client. So this is a translation of the Dutch Dental Association's guidelines on doing extensive aesthetic treatment for a patient. And they say that we should be doing it by direct test build using composite, so that's sculpting composite on the teeth to do a mock-up, or by digital demonstration by means of a digital smile design, where you look at the ideal desired position and shape of the teeth and gums and determine them in relation to the face and especially the smile. And then this smile design can be used for production of a diagnostic wax up, which is applied with a mold as an indirect test build-up or mock-up in the mouth. So when we've got organizations around the world saying this is now starting to become best practice or gold standard approaches in aesthetic dentistry, I think it's a really useful tool to have in your toolbox. And I do a mock-up for every patient, even if I'm doing a single tooth or a couple of laterals. Maybe I've got little peg laterals and I'm going to do some composite veneers or porcelain veneers. I'll get a wax up done and I'll always do a mock-up. Now, as I mentioned, it could be anything from a very simple application of composite resin to lengthen teeth, to get the patient to speak, to take some photos of them in repose to see that the amount of tooth display is age appropriate. You could do some functional checks in this situation if you wanted to. I can see immediately that the widths of the two centrals are slightly different, and that might have just been my sculpting, but that will be one of the things that we would be instructing the lab, and some photos and maybe a scan of what we've sculpted or an alginate impression of what we've built up and send it to the lab to say, okay, get some symmetry between these. But fundamentally, this is the length that we want to work to. And that will set the parameters by setting the maxillary incisal edge position for everything else about the smile. Most mock-ups today are done as a bisacryl duplication of a wax-up. So we send facially driven guidelines to the lab. They do a diagnostic wax-up. It comes back as a model. Either you're making a silicone index or maybe your lab is doing that. You fill it up with bisacryl material like Luxatemp or ProTemp, and you push it up around the teeth and wait for it to set. And here's a case where we were looking at doing veneers for some Invisalign refinements for a patient, just composite resin. We were looking at injectable or pressable veneers for this case. But we also made the patient 3D printed shells as well to test drive that. So this is a newer way of doing a mock-up, which does involve a lab fee. In fact, it says no lab fee, but actually there is a lab fee, sorry. It's clean, fast, and easy to remove, and the patient can take it home if you can take it off intact and send them away with, careful instructions not to try and do anything fancy with these, but just to pop them on like Halloween teeth that you buy at the $2 shop and try them in and show their loved ones and their friends. So increasingly, this is my go-to, will be a 3D printed mock-up. And here you can see the difference between them. In this case, I didn't mind the bisacryl. It was a slightly lighter color. So I think we chose a bleach shade. The lab will have made the shells in a B1. I think the bleach shade looked prettier. And the patient was able to give us some feedback on that and talk to us about what colors she liked and whether the shapes were appropriate. But you can see they're pretty much an exact render of each other because they've been made from a 3D digital design. And then we put together a beautiful presentation. So we shoot the patient in a little mini studio, take full face photos and video, and put together a cool little video, which I'll show you in a minute, that we play on a big screen TV and let them respond emotionally to the presentation. So let's have a look and see what we would typically do. Now, you will have noticed there that there were two options for the patient. So we played the presentation to her first without the adjustments and amendments to the teeth. And she really loved it, but she said, I think the teeth are too rounded. I want squarer incisal edges, and I want the laterals to be a little bit squarer. So we went back into the surgery. We made some very small changes just with a rubber wheel and maybe some Softlex discs. And then we took her back to the studio and we took more full face photos, dropped them back into the presentation. And what we do is normally just screen mirror onto the TV with an iPad to play it back again. So she was able then to say, yeah, I actually like that a lot more. Slightly squarer edges, flatter edges, little less rounded embrasures, and so on. So this is where it's an amazing tool to engage with patients. When we do the 3D printed resin shells, they basically, you can see them sitting on the model there, and they tend to sit labial to the final design. Now, obviously, when we're doing veneers of some kind, maybe in this case we're doing composite resin injectable veneers, and we might be doing minimal reduction of tooth enamel and really just largely an additive case. But equally, if we were doing porcelain veneers, we might be having to do some preparation. So to fix them in place, we tack them on with a tiny little dot of flowable composite, push it into place, and then the dental assistant cures it with a curing light. And that's usually retentive enough and not too difficult to get off, but retentive enough that it will stay there for the time that we're taking our photos and doing the analysis. The other thing you will have noticed is that we took video. And the reason we do that is we're looking at the dynamic smiles. So if we look at some of the works that's been done in the past by Eduardo Mann from Chile, who's published some beautiful articles on the significant difference between capturing somebody when they're talking with enthusiasm about something in their life and the mobility of the upper lip. And the amount of gingival display that we get is significantly more than we get if we just ask them to pose for a static smile. And that is particularly significant when we've got a patient who doesn't like their smile and has learned to hold the upper lip down over the teeth and, constrain their smile, or a person who's really severely impacted by the appearance of their teeth and only knows how to grimace and can't give you a natural smile to allow you to establish some of the smile parameters that you want to see, like the smile curve, to design the shape and position of the teeth. Now, there are limitations in an analog trial smile or mock-up. So this is where your lab sends you back a wax up on a stone model. And digital dentistry has transformed our ability to preview some of these cases that weren't possible in the analog world. So severe crowding, where you've got extreme malposition of teeth that are going to need orthodontic treatment, where you might have to intrude and raise the smile line by lifting the incisal edge. Very difficult for a lab doing a conventional wax up on a stone model to give you an indication that that's required. They've either got to cut the stone cast and maybe cut the gingiva if you're going to present an interpretation of orthodontic intrusion or crown lengthening. Midline changes, also very hard to correct the midline in an analog wax up, because the lab will have to either wax labially and then go back and wax all over again when they make you your final working design and model. So where you've got really over-contoured existing porcelain dentistry, I kind of like to get that off and then go back and do the mock-up. But that means the patient has to be seriously committed before we start to dismantle a whole lot of dentistry. Now, in this situation, in the analog world, I wouldn't even attempt to do a mock-up. I'd be saying to the patient, you have to have ortho. I can't do veneers in your case. But it's amazing that in the digital design world, you can simulate orthodontic tooth movement with the digital protocols. And I'll show you an example of that later. Here's the occlusal view. Another case, we've got a very prominent labially placed and rotated lateral. The rest of the teeth don't look too bad. But, if you wanted to wax it up conventionally, your lab would have that tooth poking through, or they would really be wanting to cut the cast and create the ideal shape for you. Here's an example of a midline cant and overlapping teeth, also very hard to do in an analog situation, and really bulky, thick dentistry that I'd want to be getting off and previewing. But, then the patient is absolutely signing up to definitive solutions because this is going to be irreversible. What about crown lengthening? Well, you can, in an analog world, wax over the gum. In the case on the left, we've got an old crown. The gingival margins between the two centrals are slightly different. So that's not too difficult for the lab if you instruct them to wax over the top of the gingiva. And when you go to do your mock-up in the mouth, you'll have a little layer sitting over the gum to simulate the new tooth proportions. In the case on the right, we've got a severe case of laryngopharyngeal reflux and tooth erosion, acid erosion of tooth structure. And so these teeth are actually going to need a crown lengthening procedure, which will be a surgical approach with some bone recontouring. And we were able once again to wax over the soft tissues to preview that. And here you see the mock-up in situ, simulating the impact of new tooth proportions and shapes in the toothware case and a new gingival position. With 3D printed shells, we're having tremendous success just sending the shells to a periodontist to click onto the teeth with a high level of accuracy to actually simulate the new gingival margin rather than making a surgical guide. So in many instances, I'm just sending the shells once we've done the mock-up. So let's talk about the old traditional analog workflow, which is what I used to do. So we would do the new patient exam. We would bring the patient back for an initial discussion and agreement about what we would do. As we'd finalize the treatment plan, write the report, give the patient all the fees and say, here we go, this is the plan, this is what we want to do. And then I would go away and write the lab instructions and then get the mock-up, the design back and go to the mock-up, confirm that, and then go to delivery. In the digital world, and certainly in the digital smile design world, we flipped this whole process around. It is completely reversed. And the treatment planning part doesn't come until after we've done the emotional mock-up. And I'll show you why that's important. So traditionally, these are really old photos. I did this case about 20 years ago, but it's well documented and they're really useful to understand the protocol with an analog technique. So we have facial photos that we've taken, some in repose, some smiling, some we've taken from the side, not complete profile views, but round to the side. And this allows me to have a good look at the design parameters and the things that I want to achieve in the final result. We do some close-up photos of the smile, and we'll do some intraoral photos too. And then I used to take a FaceBo record using the Koist Interfacial Analyzer, and I would mount the models on a Panadient articulator. Now, this patient had an over-erupting 1.7. It was unopposed. It was irrelevant to the treatment planning that we were considering for an aesthetic improvement for the patient. So we actually just ground it off so that we could raise the design platform up and start to analyze where the new incisor ledge position needed to be. So you can see how the upper cast is mounted on a platform, and that platform has a little dial that allows me to dial it up or down and decide. And there you can see we've just ground that 7 flat because it was irrelevant in the plan. And we were able to instruct the lab to come up with a new design. The Panadient was a very elegant little system because it had mounting plates that you could put on that gave you almost golden proportion dimensions if you felt that was something you wanted to use. It gave you bucco-palatal or buccolingual reference lines, so that if you had teeth that were slightly palatally placed, as we have here, you could ask the lab to wax everything out to a symmetrical curve and follow a smile curve from a labial perspective. And get symmetry there. So here you can see the wax up that was done at the time. And we only really waxed the areas that we needed to restore and build out. Cervically, the contour of the tooth was perfect. And so we didn't need to over wax that. And I think that's one of the things you learn when you're doing aesthetic dentistry in the analog world. You often get a case back that's bulky and maybe your lab hasn't paid attention to some of those finer points of emergence profile, interproximal shapes, embrasures, and so on. So that's a completely different lecture on smile design. But when your case comes back and wax, it should look something like this. It should have really sharp cervical margins, beautiful emergence, lots of lovely texture and line angles, embrasure shapes that you've specified. And this will be purely an additive technique. Emergence profile is really important, so understanding that teeth have 3 planes, cervical, middle, and incisal, and you want your lab to be replicating that. Here you can see in this beautiful wax up done by my technician, Brad Grobler, he's created line angles, he's got the anatomy looking quite stunning and starting to get a little bit more exacting in terms of what we require from our ceramists is really important. Previously we used to make a silicon index with a lab putty called Siltec from Ivoclar. I like this because it's got quite a high shore hardness, so it doesn't distort and flex when you're making it. And certainly when you're pushing it up into the mouth to create the overlay in the mouth. But you need to have a certain amount of thickness of the material labially, and you can see in the middle image there's almost a see-through layer as the light shines through the silicon, and it's too thin. So remember that you want sort of a uniform thickness. You can see in the cross section on the right side there that it needs to be fairly thick so that you don't get distortion when you place it in the mouth. I usually, in the old days, would cut a little V-cut and take a Sharpie and just mark a midline notch, because when you're pushing this up in your mouth, it's often easy to get disorientated in terms of where you're seating it, and that just helps locate it in relation to the frenum. So put that little midline notch in and mark it with a Sharpie. Nowadays, we tend to make a low viscosity, high viscosity impression silicon technique. So this is made nowadays off a 3D printed model. It's important that your lab washes the model really well. If you've got, if it hasn't been well washed in alcohol, then you've got the potential to have a bit of residual monomer that might be uncured completely or incompletely cured, and it can impair the setting of the silicone. So sometimes we will give them a little clean with isopropyl, and occasionally we'll put some Vaseline or a separating medium on them. And it's also really important when the lab sends you a 3D printed model that they print to the smallest dimensions that they can, so that you get the layers are thin, very thin layers, so that you get a really nice smooth surface finish on it. Nothing worse than creating a mock-up that's got sort of lines, horizontal lines across the face of it, or you can see the print layers reproduced in the mock-up. So once again, putty thickness for rigidity. And nowadays what we do, and this is DSD technique, is to go around and create V-shaped cuts all the way around to release excess material. Here it is reproduced in the mouth with a nice wax up and a nice 3D printed model design. You're going to get a beautiful render of tooth form that allows you to really evaluate properly the design and see that you're happy with it. And there are lots of materials on the market for doing this. I put a few of them there, and my favorite is Luxitem. And I also stock several shades. So I have bleach, B1, A1, A2. If I want to go darker than A2, I just use a little bit of GC Optic Glaze and tint it down to sort of an A3 or A3.5, but it would be unusual that I would be doing a mock-up in that color. There's always a little bit of flash, even with the V-cuts, and I don't worry about this because the one thing we're never going to do is give the patient a mirror and say, have a look at this. Because what do? The first thing they do is hold that mirror right up close and they spot that little bit of flash and go, oh, is this going to be here in the final result? And they start to get anxious about it. We pick up a shade tab and we just have a look at the shade. We ask the patient for feedback about the color. And before I make the mock-up, I say, what color do you have in mind for your new smile? And then we'll select our Luxatemp in that shade. In this case, we're matching to some natural teeth, so A1 seemed like an appropriate shade to select. And these are the things that we never do today. Hand the patient a mirror for approval. Let them walk over to a wall mirror because invariably they walk within about 2 centimeters of the mirror and scrutinize every little detail and flaw, including the odd air bubble and things like that you might get in it. The digital workflow is quite different for me these days. So this is how it works. I do my new patient exam because I'm digital. I can gather lots of data really quickly. And from that, I'll have a broad discussion with the patient. And my new patient exam is about 1 hour and 15 minutes. And say, if you want to move on to the next step, and by that stage, we've looked at scans and we've looked at photographs. So we've had very much a visual consultation with the patient to talk about their concerns. Then I need to move on to do a design and develop a blueprint of where we want to go with your case. And then I'll bring you back and test drive that in your mouth before we finalize the treatment plan. And that's because sometimes we do things in the mouth with the mock-up and the patient goes, actually, now that I see those 6 front teeth that I wanted you to treat, I can see that those premolars are in the shadows and really I should be widening the buccal corridor. They don't use that language, of course, but we will point out these little details when we're doing a mock-up for a patient who's insistent on limiting a treatment plan. And oftentimes I'll actually request the mock-up to be done to involve 10 or maybe 12 teeth if required, rather than just 4 or 6, so that I can show the patient the difference. And with shells, it's easy to take them in and out and, compare just doing a few teeth with, say, doing 10 teeth. Once we've done the mock-up and we've got that emotional engagement with the patient, we sit down then and we have a technical discussion. Okay, we love this. You've got tears in your eyes of joy at your beautiful new smile. We think you look gorgeous. You love it. Your husband's going to love it. Now, how do we deliver this? And so we talk about some of the biologic things that might need to be involved. It could be some orthodontic treatment to move teeth, could be crown lengthening procedures to get gingival symmetry. So there are a range of things that we will canvass in that more technical discussion once we've done the emotional one. And we'll just take a quick look at this little case. Obviously, I run a tooth wear practice, so I see lots of patients who present with tooth wear. And this gorgeous young woman came in because she had severe erosion, but also some attrition related to bruxism. And some of this was related to medication that she was taking after having a brain injury. So you can see here that we've got no tooth display in repose. And this is a woman in her 30s who should have several millimeters of tooth display in repose. You can see the profile photographs. The inclination of the teeth is pretty nice. The smile is very flat. Look at the curvature of the lower lip. And the teeth are, the smile line, when we look at the teeth, is almost concave, but it's very flat, bordering on concave compared with the lower lip. Here are the intraoral shots, which show the extent of tooth wear and acid erosion affecting posterior teeth as well as her anteriors. There are the digital scans, and you can see the attrition and the erosion combined. She'd had some ortho, so she's got a retainer wire. And then I use a module, which is an amazing tool for capturing the patient as a human articulator. So this is a functional tool that allows me to upload scans, and then using some really smart technology, infrared sensors that are on a tiara and on a little jig that's attached to the patient's lower jaw, we can get them to go through a bunch of functional movements and see how the patient's chewing. I want to see if there's any reason why I can't lengthen those teeth. And certainly looking at the chewing pathways, it looked pretty good. But then we were able to go in and say, okay, now grind your teeth for me and show me how you use your teeth. Because, this is our biggest concern. Look at the horizontal pathways. When we look at the sagittal perspective, she just got this complete sort of straight line coming forward. And I'm looking at that going, okay, now how am I going to lengthen those teeth? And if I tried to, with the forces that she's applying to the teeth, both in lateral and protrusive movements, is she going to knock off and just break my veneers? So we came to the conclusion in this case that we needed to open the bite. So Module allows me to record a new vertical dimension. And you can see here that this is the new vertical. And then we translate those anatomical and functional pathways to the new vertical to visualize where we might have space to lengthen the teeth. And you can see there that, we could have opened a little bit more, but we've still got space at the front to allow her room to lengthen her front teeth for aesthetic reasons, but still function through pathways that won't put those teeth under enormous load. Now that's an entire 3-day occlusion course, in a 30 seconds. And we do that course at the Shepperson Education on Waiheke Island. So we're going back to the design, facially driven design, and I'm using SmileCloud a lot. So this can be used on Mac or PC. I subscribe to SmileCloud. It's about €25 a month, and I can hop on and do any kind of facially driven design and create a smile frame and do a simulation what I think the teeth might look like from a library of shapes. That's a 2D design. And really what I want to do is send it now to the DSD Planning Centre, who will develop the entire smile frame based on the shapes I sent and come up with a 3D wax up. And there it is there. You can see the transparency on the left, which shows how much additional length we're adding to just 6 front teeth in this case, because we felt the buccal corridor wasn't looking too bad. And so we decided we would just restore the teeth that really needed the treatment and had the most wear. The proportions of the teeth are still shorter, rather than longer and skinnier teeth. And that is partly because we've got functional limitations in terms of how she uses her teeth. So there's the ideal design in 3D. We made in this case, I think we did a silicon index from memory. We also opened the vertical and did some work to open the bite on the lower teeth. And here you see the new bite. And then we went to create what we call the emotional mock-up. Now, I think the best example of this is a video that's been created by one of the DSD team, Eduardo Della Torre, very well-known dentist with a practice in Geneva. At the time, he was in Madrid and had a big family practice there, where they filmed a whole lot of patients that had mock-ups on their teeth, and they filmed them as they were watching the emotional presentation, as I showed you earlier. And what they were filming was actually their reactions. And what you can see here is a fairly malpositioned teeth, but in the digital world, you can create an overlay that sits buccally. And when you present a patient with a full face view on a big screen, rather than a mirror held up to scrutinize everything in detail, the reaction is totally different. So let's take a look at the video. It's really a really beautiful one. And this is it. You'll see a whole lot of patients here with mock-ups on their teeth while they're watching. So take a good look at the smiles. So you can see that, I think you can understand why Coachman calls it an emotional dental care, because we have this universal language when we're just so overwhelmed and overjoyed with what we see. And these are the reactions that I get in my office. Our New Zealanders are a little bit more understated, perhaps, than people from Madrid. But I still get tears. I still get the wow, the hands going up. I can't believe I look like that. And then the next question is usually, when can we start? Now you can see that for some of those patients, clearly there was going to be a lot more than just putting veneers on their teeth. Some of them were going to need, a round of orthodontic treatments. Some may have needed orthognathic surgery in extreme cases. Some would need crown lengthening procedures. And so their patient willingness to engage in achieving that smile when they can visualize it is much greater when we present it to them in that way. So here we are with the mock-up with my patient, and she's looking pretty happy. She's had very flat, worn teeth and didn't like them, and they were sensitive. So we did sit down and look at this together, and she gave me some feedback and said, I think they're a little rounded. I always had, for as long as I can remember, the last 10 years, I've had very flat teeth. And I'd like the edges to be a bit flatter than they are in this particular design. There's the lower arch, which we built up with direct composite. We prepped the teeth eventually with some small changes, scanned, and here we are with the provisionals, which aren't still quite as square as she would like them, but they're certainly better than they were. And we take images, once again, full face photos and videos of the provisionals, shade tab photos, go through all our phonetic and functional checks, and eventually deliver something that was more reflective of her desire for that flatter look. Everything had been functionally adjusted to allow her to grind through pathways without putting excessive load on the teeth as she was doing that. So as I mentioned, we do the emotional presentation first, and then we get into the technical discussion around the delivery. So let's look at the two ways to make a mock-up. Here's a little demonstration of loading up the silicone index with some Luxatemp, and then we're going to seat it in the mouth. I mentioned the thickness for rigidity. Normally I do this actually with an Octregate. It's a little bit easier. And what I didn't do was I didn't mark the midline with the Sharpie, which I should have done in that particular case. But here we are loading up the putty. And as the material starts to gel up, you can see little bits of excess pop out those V-cuts, so you don't have a lot of flash over the soft tissues, and you get a really beautiful render around the gingival margins of the case. Here we are taking it out, and you can see on the right that we've got a few little crumbs floating around of loose material that will pop out. But look at how beautifully that has captured the anatomy. And then palatally, I just get in with a finger or a little bit of gauze, maybe scoop out the palatal excess and just peel it away like that, and it comes away quite cleanly most of the time. So here's the patient seeing himself. Well, I'm capturing photos of him for the first time with slightly longer teeth, another tooth wear case, and it's all feeling a bit strange. He hasn't seen himself yet. So we haven't done the presentation, we're simply capturing the photos for it. And you can see he's a little bit nervous, and patients are. They are, oh, it feels like a lot of teeth. I don't know how I'm going to look. Am I going to be toothy? Will I look like a horse? These are the comments that they provide. And then we put it into the presentation, and they are over the moon when they see themselves. So you can see when I shot him by video, he's sort of excited, but he's not quite sure how it's going to look. But we're reassuring him, and I've usually got my assistant in the room saying, "You look amazing." And so we get a big smile, and then we'll play this back. And, this was a beautiful case that we did in the end. Another case where I was replacing composite resin veneers. Patient really wanted to get a sense of labial and buccal corridor volume, so he wanted a wider smile. So we did a mock-up here before we started removing the old composites to show him how it might look. And I took a whole lot of fun photos. So we just, play around with the patient and get them to laugh and talk about things that make them happy so that we can capture some really nice photographs. The 3D printed shells, here they are coming off the printer, and they'll be separated off the printer and then cured and washed, and then sectioned off and trimmed, and a little bit of OptiGlaze put on them to get a really beautiful surface finish on them. When do I use them? When do I think that they're really good? Well, Luxottemp has its limitations. When you've got really severe discoloration on teeth that you're ultimately going to mask with veneers, but you've got a very thin layer on the wax up. So in this case, I couldn't give the patient as ideal an idea of the final result, because we had a lot of shine through of the discoloration. So this would have been a much better case actually to have done shells. Here you can see a patient with a very yellow front tooth. We used bisacryl here, and it didn't look quite so pretty. So it would have been a nice case to do in shells. Another older man with a debilitated dentition who was petrified of dentistry. And if I had tried to do a bisacryl mock-up on this man and then had the material lock into all the undercuts, it would have just been a nightmare. He would have needed to be sedated to have it all removed, because he was that terrified of dentistry. Even scanning him was a challenge. So in this case, we made a full arch of shells to try and to move him to some definitive dentistry, and he coped with that fine, and it was really easy to remove at the end of the appointment. Sometimes we're shifting a midline in our planning, and we might simulate what that looks like when we're trying to do it orthodontically or restoratively, or giving the patient choices. And so when you lay, this is a beautiful photograph of a mock-up laid over the top of existing teeth that might either be intruded or where the midline might be shifted. It's going to have tooth structure showing underneath, where we'll sometimes apply a little bit of pink flowable to the interproximal areas to block out any underlying tooth and get that nice papilla shape coming down between the teeth at the mock-up. And where we've got existing teeth visible below the mock-up, we block out with a non-toxic face paint, black face paint, or you might have seen people doing that with a Sharpie. So let's take a look. There are the shells on the model. They've been glazed. They click on quite precisely over the existing teeth to simulate some tooth movement and new shapes. When we're ready to go to the mouth, we fill them with just a little bit of flowable. You can see the quantity that I'm putting on there. And then we will tack them up into position and cure them with the light. You don't want to have too much flowable, because you don't want a lot of excess coming out. So this was a case we were actually doing in a DSD course live in a hotel room. So we had the patient sitting up, and you can see you just tack them into place very gently. Look at the underlying tooth structure hanging down below. So this is a case where we're planning to intrude very prominent teeth with orthodontic treatment. So the dental assistant will then go in and just cure that. You'll see here where we may be painting on. In this case, we're using a little Sharpie just to go underneath and block out the tooth display, so that when we take the photograph, it looks like we've got the correct length of the tooth in the final image. Here we are putting just a little pink flowable on and just applying that into proximally where we had shine through of existing teeth, because we were also simulating a midline shift. And you can just take some normal A1 flow, and if you've got a wee bit of tint, red orange tint, you can mix that in and change the color of it and apply it that way. There you see the Sharpies, and as I said, mirrors a band. Okay, good, thank you. So this was a patient being offered a very simple orthodontic treatment plan, which involved no midline shift, but you can see to start with, she's got a facial midline and a dental midline that don't coincide. So the treatment discussion was, if we're going to go to the trouble of orthodontic treatment, do we shift the midline or do we not? And so we gave her the option of broadening the arches, intruding some teeth with or without the midline, and actually made her 2 sets of shells to be able to test drive that. What about posterior shells? Let's talk about those quickly, and then we're not too far from finishing, Alex, and we can go to some questions. So here was another toothware patient, man in his 50s with very worn teeth. He had a crossbite, so he was a class 3, and it's a little hard to see. It looks like he's edge to edge, but actually the upper incisors are tucked in behind the lower incisors. Posterior wear, and in this case, it was going to be impossible to lengthen his front teeth based on that class 3 relationship without opening the vertical. So we dialed in some new verticals to test drive them in Modjaw, went to DSD for facially driven planning. There's the design and transparency. There's the upper design with the existing dentition. Not possible. Look at the position, look at the bite and the position of the lower incisors. But if we open the vertical, suddenly we can create an edge-to-edge occlusion, and this is doable. So that meant creating something on posterior teeth and waxing up posteriors with a new vertical, which we did, as you can see here, and then taking that to the mouth to be able to properly test drive. So in this case, my lab reproduced that wax up with 3D printed shells that we were able to tack on, and then do a traditional bisacryl mock-up in the upper arch to test it. That's the new occlusion with the upper arch restored, the lower arch vertical raised. And here's what they look like on the model. So the little row of 4 teeth all joined together. We're tacking them on with a little bit of flowable resin. They sit very snugly on the teeth. And here you can see them in situ before I've done the mock-up in the upper arch. Now, clearly here we haven't done anything with the lower incisors, and they were going to have a little bit of orthodontic treatment to realign them and just correct the crowding and see if we, with a little stripping, whether we could create a little bit of an overjet for him. Here he is with the overlays on the lower and the bisacral mock-up in the upper to test drive the smile, looking like a completely different man. Every now and then we do a bonded mock-up. And when do we do this, and why do we do it, and how does it happen? So here's another case that we're working on at the moment that's currently in Australia being manufactured in ceramic. This is a patient with tooth wear. Obviously, we'll go to her close-up photographs. You can see the extent of the wear. And she had a combination of sleep disorder, breathing, reflux associated with that, and had become quite overclosed. Here's the scan. You can see the extent of the wear, dentition's overclosed. So we've got quite a bit of frictional contact because the vertical's less at the front. We did a smile cloud design just to create a smile frame and simulate how she might look. And then my lab turned that design into 3D and printed prepless 3D printed shells in a GC temp print material. Now, this was a patient who lived out of New Zealand and was flying in for treatment, but she was also going away to London for the holidays and traveling in Europe for about 3 months. And she wanted a beautiful new smile to meet the family who she hadn't seen since before COVID. So we actually did the mock-up with the intention that if I wanted to bond these in place and she was happy with the appearance of the teeth, that we could do so. here we are in video, before and after. She's thrilled. This is the material, GC10 print. It's a class 2A biocompatible material, not intended for long-term use, but for about 3 months until she was going to be able to get back to me, we could bond it in place. So in this particular case, I air abraded the material, applied an MDP monomer, etched and bonded the teeth, and then cemented one by one each of these prepless overlays, cleaned up all the cement, made sure that she could floss and clean and all that sort of thing. And remember, they were prepless. So because of the tooth wear, we were able to get away with an additive technique. This is what they looked like when I saw her again in March, just a few weeks ago, looking amazing. And she'd been able to test drive them, try them out with food and drink and talking, and come back to me. And so we used them as then the bonded in situ mock-up, which would drive a guided prep. So from that point, I was able to use depth prep burrs and cut through it to create the final preps, and we're converting that now to ceramic. Finally, just the mock-up is a surgical guide. So another patient with tooth wear, but quite a significant cant to the maxilla and asymmetrical gingival display. You can see on the right, we're seeing more gum than we are on the left, and some teeth are, showing more gum, particularly the premolars. So we did a DSD design. Here was our first mock-up based on existing gingival levels. Now, the patient hadn't noticed the gingival asymmetry at the beginning, and we hadn't discussed it. She was more concerned about the color and the sensitivity of the teeth. So once we improved her smile with the mock-up, she said, actually, I don't like my smile because I'm showing more gum on one side than the other. So here we are. And she was a patient who'd come in with an Instagram image of, smiles that she really liked, and she wanted us to copy this. So we did 3D printed shells in A1. This is mock-up number 1. You can see her natural teeth there. She also said, I don't think the shapes actually reflect my natural tooth shape, even though we more or less copied the Instagram images. So I went back to the lab and I said, okay, wax this again, replicate her shapes, and lift the gingiva so that we can try that in and then have a conversation about how we manifest that in the final result. So these are the teeth that we're going to have crown lengthening marked with the X. Here's the mock-up number 2 with the shells, and she absolutely loved it. Didn't think the teeth were white enough, but loved the gingival display. And I said, okay, well, you can achieve that with some orthodontic treatment, or you can achieve it with crown lengthening. She didn't want to wait to do orthos, so we did crown lengthening. And those shells were supplied to the periodontist to click onto the teeth to guide the final gingival contours. And here's the finished case with much whiter teeth, with much more gingival symmetry, taken a week or so after the veneers went in. We subsequently went in and did some buccal composites on the 6s because they were visible and a bit yellow in her big smile, and took some photos recently, which unfortunately I don't have. So, Alex, shall we stop sharing at that point and hop back into everybody?
Yes, thank you. No, thank you so much. I think I learned, and I think, I've seen a few presentations on smile design and the motivational mock-up, but clearly there's been a few additions and changes over time, especially I think what's fascinating is that, the dynamic digital video display, I can imagine that provides a lot more flexibility and probably answers some of the questions I had in terms of sometimes the challenges you may have where, maybe the mock-up wasn't exactly what you need and you want to, quickly do that. And maybe we'll ask some questions in regards to how you used to do or navigate that challenge. Obviously, I understand there was limitations, and that's why the solution was created. But for most people, maybe they don't have that capability yet. So maybe we'll start there.
Sure.
Yeah. What did you do? How did you navigate those issues and challenges you had?
Specifically, which ones, Alex, are you referring
Specifically
to?
To where And I'll ask a few. This is a multi-step question, but I'll ask the first one, which is where you've done the mock-up and some adjustment is needed, where, as you were able to do in that video kind of display, where it's not so easy to make an adjustment chair side.
No, I think, the mock-up is normally, I'm not doing a mock-up in a hotel room except for a DSD course, but I would be popping, and you don't have to have a photo studio. So you can have a place in the corner of your surgery against a neutral background to take these amazing photographs. And maybe you replay the presentation on the desktop that's sitting on your bench that runs your practice management software. So there are lots of ways that you can do it. And before I set up a proper photo studio on my consult room and put a big smart TV up on the wall, that was how I used to do it. So if I do have changes and they're substantial changes, then what I'll do is I'll write notes. And I've got some quick notes, which is like a checklist of all the things that the patient and I have talked about, which is in my practice management software. And I'll document that. And if I feel that we're really off the mark, for example, the patient with the gingival display that we just looked at, I will go, let's make you a second. We'll just make that happen, because you're now seeing things, and I call it the carpet and curtains effect. If you're going to renovate a room, and you decide, right, I've got to change the curtains and the carpet, and then you do that, and they look beautiful, and then you look at your old couches and go, damn, I need to replace the couches, So that was a little bit of what happened there with that patient. And I think, particularly in aesthetic dentistry, there are big red flags that go up with some patients. And that case, I had anticipated the red flags, because we'd asked appropriate questions in a dental history form about patient expectations. And I think when a patient comes in and they've got, half a dozen Instagram images of veneers that they really like, and they're saying, I want to look like Kim Kardashian, you suddenly go, there's a disconnect between what's real biologically and we can achieve for you and what you actually want. So I think it's better to get it, to make the mistakes at the mock-up stage and do it again and have it redone, even though there's a lab fee. The lab fee for a second mock-up is a heck of a lot less than the lab fee for a second lot of veneers, and then dealing with an unhappy patient or a patient complaint. So, the price of that process is not worth it, and it's better to do the second mock-up and just wear the cost for that.
Yeah, and I think that speaks to, especially most of these cases will involve some form of aesthetics, and a consult that I just had today of agenic laterals and gummy smile, and they're coming in just for the implants to replace the laterals, but then you start having, as you say, the curtains, the couches conversation. And now we're talking, are we talking orthodontics? Are we talking crown lengthening? Are we talking restorative changes? And it becomes this can of worms that the initial referral maybe hadn't suggested. But I think, and then I'll add the classic situation where there's a wedding as well.
There's a time.
Exactly, and then there's the time frame. But I think you're absolutely right that I can't emphasize enough how important it is to be slow and just set the right expectations of not rushing that diagnostic stage. And if there are timeline restrictions, finding, as you've had in your case, some sort of temporary solutions that can achieve the short-term results that are needed.
I do also think, Alex, that there's value in making 3D printed shells and sending the patient away with them, or on occasion, obviously you can't do that where they're sitting over the gingiva, and you're simulating crown lengthening. You can send them away and they can tack them into place, and well made and well designed. They click into position, but they'll click off really easily. But they're stable enough to take home and try at home. But every now and then, I think it's worth actually bonding some shells in place and sending people away with them. Hopefully
they come back.
Hopefully, well, maybe you spot etch them, and you just send them away for a couple of days, and that's all true.
They might enjoy it too much.
But particularly when it comes to color, and we will take the shells if we find the color that the patient likes, particularly for patients who want really white teeth. Then the lab will mix colors, they'll mix shades together to give me a really white shell. And while it doesn't have the optical properties of ceramic, the patient will send that back to the lab and say, the patient signed off on this. And for difficult patients, I'll actually get them to sign off. Yeah.
Yes. No, that makes sense. Now, talking about shells, we had a question. How do you like to remove these shells, assuming they're obviously bonded on or spot etched? Are you using a scaler? Do you have a particular instrument that you like to do?
Excavator, a scaler probe sometimes. If they're actually not spot bonded, so they're spot tacked. I think that's really important to note, that we're not treating the enamel surface in any way. There's no acid etch. There's no bonding agent going onto the enamel. All you're doing is putting flowable onto the surface of the 3D printed resin and pushing them into position. And as we all know, that if you don't etch enamel, nothing really sticks to it. So, so they're very easy just to pop off.
Yeah,
very simple.
No, that makes sense. Now, a question kind of related to how you're communicating with your specialists and the crown lengthening, and I'll have a question about that. But one of the questions was, where you are considering on cases needing orthodontics, crown lengthening, how are you communicating with your specialists so that they're achieving, their intended goal, or providing feedback to notify you of the challenges that may, be encountered in those procedures?
Yeah, that's a really good question. And I think it's a matter of building relationships with specialists who understand your protocols and your preferred protocols, and being able to set up a pre-design meeting, I think by Zoom or whatever, online chat you prefer to use. So I find, specialists are busy, we're busy. Finding 10 minutes to have a quick chat about a case. I'll often send just a series of photos and say, here's what I'm thinking. Let's just look at this quickly before I get a mock-up done, or I might defer a mock-up if I don't think the patient needs orthodontic motivation, for example. And I've got enough awareness of things like phenotype and some of the biologic risk around some of these protocols to be able to say to the patient, well, look, it's highly likely that this is going to be a surgical procedure that will involve a little bit of bone removal, an apically reposition, flap, or it's not just going to be whip in there with a laser, or electrosurgeon takes some soft tissue away. So understanding the biology before you make undertakings to the patient and before you factor in the design. But as you found with you saw with that last patient, we worked with the existing tissues. And then the patient said, actually, I don't like this. Now that I see it differently, let's look at it differently. So we had to change tack. We had to set up the consultation with the periodontist and say, this is what we're thinking. Orthodontics was off the table for the patient. So I think we're sharing visual information, and certainly all the 2D and facially driven planning that I do with DSD is shared all the time with my specialists. And they get to the point now where they go, okay, we're mid-treatment with an ortho case that's got peg laterals, and we want Andrea to put some veneers on it. Let me, we're not quite at the penultimate aligner, but let's send the case to her. She can scan it, do a bit of DSD and get some photos, and then tell me if I need to move teeth any more than I have before we finalize the treatment plan. So we're often doing that together.
And are you incorporating CBCT into your orthodontics or crown lengthening cases, or not as much?
It depends. So sometimes I might be getting a CBCT and doing 3D planning with CBCT. And other times I might be, where it's minor adjustments. For example, that last case, I'll let the specialist do the CBCT and make the clinical decision around the management of that.
That makes sense. Now, some questions in regards to the patient and their journey. One related to perhaps pre-mock-up? Now, I understand, obviously, based on your practice, most patients probably have an understanding what they're getting into in terms of coming to yourself for a new patient consultation. But for those in a general practice where perhaps the patient hasn't come in with initial aesthetic concerns or tooth wear concerns, however, on the examination, those are presented and photos are presented and that is discussed.
Yep.
How do you, or what suggestions would you give to someone in terms of communication to help perhaps guide that patient towards exploring the mock-up? Any advice around that?
Well, I think mastering dental photography is a game changer for practice. And so mastering the good full face photograph is a game changer as well. So
what is it about the full face in particular?
It's just being able to get a head and natural head position, getting specific shots, repose, a profile smile, what we call in the DST world the 12 o'clock shot, which is, head down and smile and like this, eyes at camera, so that you can see that buccolabial, sort of buccopalatal position of teeth in relation to the smile curve. And being able to steer the conversation away, perhaps addressing the primary concern that the patients come in for first, but then saying, as part of my examination today, I've taken the time to look at your mouth as a whole, and I want to walk you through some of my observations. And we bring the photos up and we walk through them, both starting with the full face photos and not going straight to the teeth, but being able to step back at the patient and go, let's look holistically at this case with a full face photo, and then we'll start to zoom in on some of the, the micro aesthetic details that relate to the teeth themselves. So thinking macro as opposed to micro, and then highlighting some of the things that you've seen and saying to the patient, is that something you've been aware of? Is it something that concerns you? Is it something you'd like me to consider in my treatment plan? And you'll know pretty quickly whether the patient is going to be receptive to that with those questions.
And then let's say the patient is interested.
Mm-hmm.
How would you suggest the logistics, and how much time are you spending? Now, obviously, again, you're in your situation with the photography, the scans. Mm-hmm. Is there anything special that you're doing in that initial appointment that you've seen, or common mistakes perhaps that you've seen in that first appointment where that leads to the wrong mock-up or the wrong situation? Are there certain tips there?
I think the photographs are important. If you've got a face in natural head position, you to act like it's in yellow head childish, right? You're going to get a completely distorted smile curve. I know I'm probably looking like an idiot at the moment, but that full face front on photo and being able to, let me give you an example here with the camera. So you really want a patient to be natural head position, equal view of the ears, and you want them to be able to go, ha, 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 so that you can actually see the edges of the teeth and you can see the embrasures. If they just go, the lips covering the teeth. So you can't really make an accurate diagnosis. So I think that's the one photograph that is absolutely critical. Full face, full smile, teeth slightly apart, head in natural head position. Important step. If you're scanning, it's brilliant. You can get a 3D model of the mouth in no time, but not everyone's digital. So my recommendation would be that you actually make a dedicated appointment to bring them back to gather records. So before I was digital, that's what I used to do. Mm-hmm. Well, look, the next step is I need to get more information. I need to get more photos, or I need to get models of your mouth. And once I've got that in front of me, then I can write some guidelines for my lab to develop a blueprint so that we can test drive this in your mouth and give you some comfort around where you might go with your treatment, or some visualization before we actually do anything. And so
how much time would you allocate to that?
Normally, in my previous new patient exam, when I wasn't digital, I would bring the patient back for another 45 minutes, sometimes as long as an hour if I wanted to get some different bite records with a leaf gauge, or I was opening the vertical. and if you're a dentist who is doing, say, a half-hour new patient exam, maybe you're an associate, and that's the routine in the practice. You have control over that, and you are working with the practice protocols. There are a lot of dentists in that situation. You're going to want to bring the patient back because it isn't enough time to do your exam and get all the records, even if you are digital.
Yes.
So build some value into that too. And I always say learning and earning don't always go together. So when you're starting out doing this for the first few times, you may want to discount your fee or do it for nothing as part of the learning curve, assuming that if you're an associate, the principal dentist is okay with that. Or you might want to do, start with a nominal fee that covers your lab costs, and maybe give your time for free. And then as you build your confidence, you'll build in the true value of that appointment with a patient.
Yeah, no, I think that's very sensible. And then to lead that into the next, so then you spent, let's say, 45, 60 minutes for record taking, and further diagnostics where that's necessary. And then you're bringing that patient back a few weeks later for the mock-up trial. Are you spending, how much time are you spending in that appointment making that assessment?
Yeah, so that appointment I normally make an hour long. So that gives me time to, and the template that you saw for the presentation is all done prior to the patient coming. So it's set up in Keynote or PowerPoint by one of my team members, and all the photos, all the scan images have been dropped into that in advance, all the before photos and the video. And then all I'm doing is I'm creating the mock-up, putting it in the mouth. If we're doing it with bisacryl, there's a little bit more cleanup. There's a bit more flash, on the palatal and on the occlusal surfaces to clean up. And then we take the patient's photos, video. The patient sits and relaxes. They're not allowed to take a selfie. One of the team will come in and have a chat to them about their treatment and what's happening in their life. And then I'll go out. It'll take about 10 minutes. And either I or the team will quickly drop the camera card into a card reader and drag across the photos that we want to put into the presentation. We do that on an iMac, and we share it to an iPad.
Yeah,
and then we pop through. We've got Apple TV running, smart TV. We simply AirPlay to the TV when we're ready. Yeah, that's how it works. And that's normally an hour. Then I take the patient, so we have a chat. We have a bit of a chat about it. We talk about anything they want to change. And then we go back to the surgery. And before I take everything off, we sit down at my desk and we talk about some of the technical things. And I've got all the design files there from DSD in the PowerPoint presentation. So we walk through some of that, and I say, to achieve this, we're going to have to do X, Y, and Z. And this is roughly the duration of the treatment plan. Have you thought about the material that you want me to use here? We walk through broadly the costs. We may have talked about that in the new patient exam first. And then I say, okay, great. I'll put a proper informed consent document together for you. I go away and write that. And it's often just dropping slides and images in, and then putting my, treatment plan with fee structure together.
And obviously I understand that. Is that approach how, let's say for someone who is getting into this kind of area where perhaps they're doing not a full mouth and not a full wear case, but several teeth, is that time frame slightly less, or do you?
Slightly less. Yes, if I just had a couple of laterals or I had 4 front teeth, we might spend half an hour, at the most on that, because it will be quick. Yeah.
And one of the questions is, in that motivational mock-up, are there specific questions that you found to be very important to get patient input and feedback?
Yes, I think the important thing is not to talk to begin with. It's really, particularly when the patient is emotional, and if you're not comfortable with emotion, it's really easy to suddenly want to talk and go all technical or dental, in the conversation. You actually just have to sit there quietly and go, how was that? And they just go, that was incredible. I can't believe that I look like that. Or, yeah, I love it. Or I love it, but there's a couple of things I like to change. Great. Let's chat about what you'd like to change. So they sometimes leap up and point at things on the TV. Sometimes we go back to the iPad and look at it, just side by side. And we talk through, and I go, no problem. Anything you'd like to provide feedback on, please do so. And this is your time. This is your time to really get the smile that you're after. So I think giving the patient lots of permission in verbal and non-verbal ways to provide feedback is important. And don't go all dental.
Yeah. I can imagine. That's what the report afterwards provides. That makes a lot of sense. Well, thank you so much. I have one last question. This is for me personally. I love the concept of the shells for crown lengthening. What were you doing prior to that? That also worked relatively well.
Yeah, we were making, we did experiment with a DSD double guide. So that was where the DSD Planning Centre will make a guide, assuming that you've sent them a CBCT, that replicates the final gingival margin plus the final, osseous contour. But the difficulty I had with that was at the times I would get work back that didn't reflect necessarily the taper of the tooth, or the way you needed to alter bone between the line angles of the teeth, and those line angles go all the way up the root, of a central incisor. So what I was finding was that the feedback from the periodontist was they'd get it back and they go, yeah, it's great for gingival margins, but actually that made the contour a little bit wide,
always kind of would have.
Yeah,
with the printing rounded the edges.
Yeah, exactly, more rounded rather than a tooth that might be more like like an ice cream cone. It's a bit more liquid. So I have found that I prefer to leave that bone decision really to the specialists, and they prefer to have something that gives them a very clear guide as to the cervical contours, at the gingival margin, and then they'll work with that. And, sometimes, even when I look back at that last case that we did with the shells, we did crown lengthening on the 1-1, originally the 2-1. The 1-1 was, sat lower than the 2-1, which is why we were crown lengthening, but we got a little bit of tissue shift even then. And I ended up with slight asymmetries between the 1-1 and 2-1, even at the end of treatment. So it's hard managing soft tissues, and having an adequate healing time, I think, is also really critical before you go on to do the final work, particularly if there's a thin phenotype. You might wait. I've heard Tony Rotondo talking about this. He may wait as long as 9 months, after the surgery is done, to do the definitive work. So a thicker, phenotype is a little bit easier to work with and more predictable.
Yeah, no, wonderful.
I did used to make a suck down, Alex, as well.
No, I understand. No. But I think for the suck down, I think the flexibility of the suck down sometimes is the challenge.
Yeah, it is.
But Andrea, that was fantastic. It was very, very greatly appreciated. We've had, gone for almost an hour and a half at this point, and I just wanted to say thank you so much. For anyone interested in finding out more about Dr. Andrea Shepperson, there'll be more links in the post-webinar emails, but there's a link down below as well. But please check her out, and thank you again so much for tonight.
Pleasure. Lovely to be with you all. Thanks, Alex.